I think invite Dr. N. Khanna. We'll be talking chlorthalidone, hypertension management and beyond. Dr. Khanna.
So this is the last session, but one of the most important session, and I'm going to be talking today about the chlorthalidone in hypertension management and beyond. So just to give you and set the ball rolling, worldwide we have an estimated 1.13 billion people who suffer from hypertension. And if you go on to the new guidelines and the new cutoff levels, the number of hypertensives would be much more. If you look at the overall prevalence of hypertension, it is around 30.7%. And what is seen in that it increases with age, with the maximum being in the age bracket of 65 to 75 years. What are the consequences? We all know that uncontrolled hypertension actually leads to chronic damage to the endothelium. And this is reflected in brain by transient ischemic attack, stroke, in peripheral arteries as peripheral arterial disease, gangrene, and in heart as left ventricular hypertrophy, hypertensive heart disease, heart failure, and in kidneys as chronic kidney disease, and in eyes as retinopathy, and many more effects of chronic uncontrolled hypertension. The reverse of that is also very true. If we happen to lower the blood pressure by any means, even a lowering of 10 millimeter systolic and 5 millimeter diastolic pressure would reduce the stroke by 36%, heart failure by 43%, congestive heart failure by 16%, and cardiovascular mortality by 18%, and all-cause mortality by 11%. So that it becomes very important, not only that we need to have our blood pressure in the right range, but if we are hypertensive, we need to control it well. And if we do control it well, there is a very strong evidence that we will have major cardiovascular mortality benefits and also morbidity benefits. Now let's see, I am supposed to be talking about thiazide and thiazide-like drugs. So let's see the thiazides. These are the first line of management, one of the first line of management in hypertension. And this has been established also from the Cochrane analysis. Most of the evidence demonstrated that the first line low dose thiazide reduced mortality, stroke, and heart attack. No other drug class improved health outcomes better than low dose thiazides. This has also been recommended by various hypertension guidelines by American College of Cardiology, European Society of Cardiology, Indian Guidelines for Hypertension, European Society of Cardiology, and WHO guidelines. This is one of the best initial choice as a single drug therapy because thiazide diuretics, especially chlorthalidone or CCBs, are the best initial choice for a single drug therapy. This was according to ACC AHA guidelines. And if you look at chlorthalidone out of this group, it is one of the primary agents to be used and most effectively used in blood pressure control. It is preferred because of bigger half-life and proven trials to back the reduction in cardiovascular events. It is one of the drugs indicated on the basis of antihypertensive treatment by the European Society and European Heart Association in 2018 guidelines, and it has a definite reduction in BP control and cardiovascular events in various randomized controlled trials. And this is also the drug of choice in treatment of resistant hypertension. This has been also recommended by the Indian guidelines on hypertension, and it is the preferred drug over hydrochlorothiazide as an antihypertensive. Now let's look at this, claims. What is the clinical efficacy of chlorthalidone as an hypertensive, antihypertensive? This slide compares chlorthalidone, amlodipine, and lisinopril. This was published in JAMA, and what it shows that chlorthalidone is a better BP, has a better systolic BP control as compared to amlodipine and lisinopril. It also has a better 24-hour and nighttime BP control as compared to hydrochlorothiazide. And it has a superior blood pressure control over indapamide. And So it is a better drug than these drugs in terms of good blood pressure control. Now, what happens, what are the effects beyond blood pressure control? Chlorthalidone has shown to have pleiotropic effects. It inhibits carbonic anhydrase mediated platelet aggregation. It promotes angiogenesis. It reduces vascular permeability. It improves endothelial dysfunction, and reduces albumin permeation and reduces TGF beta mediated renal dysfunction. Now, various trials have been done. ALAHAT is one of the most important trial, and it shows that combined cardiovascular disease and heart failure was better. I mean, the control was much better and there was a reduction when we were using chlorthalidone therapy. It has a role in prevention of heart failure, and it actually then thiazide diuretics, although indipamide also is a close competitor in this category. The thiazide type diuretic, especially chlorthalidone, was superior to the calcium channel blocker, amlodipine, and ACE inhibitors in preventing heart failure, and it reduces the risk of HFrEF more than amlodipine. In terms of stroke reduction, this was from the SHEP trial, which was published in JAMA in 1991. The stroke reduction was to the tune of 36% by the use of chlorthalidone, and it was seen that the mortality benefit was also there as compared to hydrochlorothiazide in these patients. It has better cardiovascular risk reduction than indipamide, and you can see this has a better reduction in terms of early morning protection of MI, cardiovascular risk, also stroke reduction, and also reduction in overall cardiovascular mortality. Now, what happens in diabetic patients, diabetic hypertensive patients? Randomized trials of chlorthalidone and indipamide that induce substantial number of patients with diabetes have consistently demonstrated cardiovascular benefits. This was also seen in the ALAHAT trial. And in terms of treatment strategies in people with diabetes, it is recommended to initiate treatment with the combination of RAS inhibitors or along with, it is recommended that RAS blockers should be given along with CCB or thiazide-like diuretics like chlorthalidone. In ALAHAT diabetic extension study, we had 22,418 participants, and they were followed for 6.9 years. And it was seen that chlorthalidone had lowest heart hazard ratio for cardiovascular mortality, total mortality, non-cardiovascular mortality, stroke, and stroke in patients who develop incidence of diabetes. Now, what happens in chronic kidney disease? Dr. Kher would be the most important person to talk about it. There was a trial called CLIC trial, chlorthalidone for hypertension in advanced chronic kidney disease. Here, 160 patients on stage 4 CKD were enrolled with a GFR between 15 to 30. And out of this 160 patients, 76% had diabetes mellitus and 96% were receiving loop diuretics. Chlorthalidone has at an initial dose of 12.5 milligram per day was given, and this dose was increased every month if needed to a maximum dose of 50 milligram per day, and this was compared with the treatment with placebo, and the study duration was 12 weeks. The primary outcomes in the study design were a change in 24 hours ambulatory systolic blood pressure from baseline to 3 months. And also the secondary outcomes were, or endpoints were, change from baseline to 12 weeks in urinary albumin to creatinine ratio, change in NT-proBNP level, change in plasma renin and aldosterone levels, and total body volume. It was seen that there was higher reduction in systolic blood pressure with chlorthalidone and lower percentage change in urinary albumin to creatinine ratio with chlorthalidone in these patients. So in conclusion, among patients with advanced kidney disease, and poorly controlled hypertension, chlorthalidone therapy improved blood pressure control at 3 months as compared to placebo. This was published by Dr. Rajiv Agarwal et al. In New England Journal of Medicine in 2021. So in conclusion, high blood pressure is the leading cause of cardiovascular mortality and morbidity. First-line dose, low-dose thiazide treatment reduced mortality, stroke, and heart attacks. Thiazide diuretics are recommended by various guidelines as well as by international textbooks. And chlorthalidone is preferred on basis of its prolonged half-life and proven trial results in terms of reduction for cardiovascular endpoints and death. It has a more sustained 24 hours BP control, and various clinical trials have shown that it benefits in cardiovascular outcomes like heart failure, stroke, and mortality. And it is also recommended in the treatment of diabetic hypertension. And recent CLIC trial has shown clinical efficacy in patients with CKD with hypertension. So I'll end here, and maybe we can have all the speakers and have a discussion in the end.